Hi, my name is Rachel Baden, and I'm the chair for the Department of Medicine at Highland Hospital. I'm also a faculty member and attending physician in the Division of Infectious Disease. And today I'm going to talk to you about evaluation of fever in a hospitalized patient. Any discussion about fever should really start with a definition of fever. An individual is considered to have a fever when he or she has a measured temperature of 100.4 or Fahrenheit or 38 degrees Celsius or greater. Today, to frame our discussion about fever, I'm going to work with a mnemonic that I've created for you. Fever workup starts with F, which is pharmacy or drugs, E for embolism or PEDVT, V for veins or IVs or central catheters, E again, which is event related to blood transfusion, R for respiratory infections or pneumonia, W for wound infections, and U for urine. Drug fever, it can be really helpful to evaluate for drug fever if there's a rash or eosinophilia present, because that helps clinch the diagnosis. But this really is a diagnosis of exclusion. Common classes of drugs that cause fever are anticonvulsants, antimicrobials, especially the beta-lactams and the sulfonamides, but really any drug can cause fever. The list is long and endless. Consider malignant hyperthermia if the patient has recently received anesthesia, and consider NMS or neuroleptic malignant syndrome if they'd had Haldol or certain other antipsychotics and are also demonstrating rigidity, altered mental status, and autonomic instability along with their fever. E or embolism, PEDVT. This is another important consideration when evaluating a patient with fever. Consider it in a patient who has pleuritic chest pain, but maybe other respiratory symptoms such as cough or shortness of breath, as well as tachycardia and risk factors for thrombosis. These would include prolonged immobilization, which is common in our hospitalized patients, and whether or not they are or are not on prophylaxis for DVT. You should evaluate with pulse oximetry and possibly an ABG to see if there's an AA gradient. It's really widely debated how often fever is a presenting sign of a pulmonary embolism. And the literature spans from anywhere from 5% to 50%, depending on the study. But really, in reality, that pneumonia would be much more common than a PE in a patient with fever and respiratory symptoms. So you should really start with a chest x-ray and then take your evaluation from there. It's always good to have a high suspicion for this diagnosis and keep it on your differential, as a PE is a diagnosis you certainly don't want to miss. Next is V for veins, and this really informs your evaluation of patients who have fever, who may be at risk for infections from an IV or other central catheter. You need to carefully examine all the insertion sites and look for signs of infection, such as erythema, pain, swelling, or any drains at the site of insertion for these IV catheters, PICC lines, or central lines. You should draw peripheral blood cultures and blood cultures off of these lines to evaluate them as potential sources of infection. Next is E again, events related to blood transfusion. So this is really a whole lecture in and of itself, but I wanted to raise this as part of your differential for fever in a hospitalized patient. There's a wide spectrum of different reactions related to transfusions, anything from anaphylaxis, acute hemolytic syndromes, infections, and acute lung injury, to name a few. You need to take a good history and do a good exam to inform the assessment, but be aware of this important etiology of fever in a hospitalized patient to help inform your decision-making and workup when they're receiving blood transfusions or blood products. Next is R for respiratory infections. This includes hospital-acquired pneumonia and ventilator-associated pneumonia. This is an incredibly common cause of fever in a hospitalized patient and should be considered in any differential, especially in patients who are on or have recently been on the ventilator. Evaluate for increased oxygen demand, sputum production or secretion, increase in vent settings, cough, or any change in respiratory status, such as increased breath or breathing. Your evaluation for this should always start with a chest x-ray. Next is W for wounds. This one is easily explained. You may have surgical patients on your service or patients who have had recent interventions, and when evaluating their fever, you should examine any surgical sites for erythema, drainage, and tenderness that may be a sign of an infected wound or surgical site infection. Last but not least is urinary tract infections. No talk about fever in a hospitalized patient would be complete without it. This is especially important to consider in a patient who has a Foley catheter or recently had one removed. You need to consider in part of your evaluation that it's sometimes hard to differentiate between infection versus colonization of the urinary tract. Commonly, patients who have catheters will have bacteriuria and pyuria, and this does not necessarily mean that they have an infection. You only treat if there are symptoms, fever being one, but you need to exclude other sources of the fever, and you need to look for signs to attribute the fever to the urinary tract, such as suprapubic pain or dysuria. Remember, in patients with spinal cord injuries, the symptoms can be somewhat atypical. They may have things like increased spasticity or more nonspecific things such as malaise. So in terms of diagnostics and treatment of a patient with fever in the hospital, you always should get a full set of vitals, including checking their oxygen saturation. You need to examine the patient and take a really good history for all the reasons I've outlined in this discussion. You can tailor your diagnostics according to findings, but usually it's reasonable to start with a chest x-ray, blood cultures, and possibly urine cultures, and then move from there. You should consider starting empiric antibiotics in any unstable patient and in any patient in whom you identify a likely source. So in summary, for your evaluation of fever in a hospitalized patient, you're going to do a fever workup. You're going to consider F for pharmacy, E for embolism or PEDVT, V for an evaluation of veins, their IVs and central catheters, E, event related to blood transfusion, R, respiratory infections, W, wound infections, and U, urinary tract infections. Fever workup. Thank you.